Greetings, everyone. My name is Amal Matu, and I'm faculty here at University of Maryland, and welcome to our Crashing Patient Conference. For those of you that are interested in getting CME credit for the lectures that you're going to see, you can get CME credit on EMedHome. Check it out at www.EMedHome.com. And for those people that want live lectures, we're going to be right back here in October of 2013. Hope to see you then. Good afternoon, everyone. My name is John Greenwood. I'm one of the faculty members here at University of Maryland. And what I'm going to talk to you about today is tracheostomy emergencies, and specifically some high-risk topics that you need to know, as well as how to manage them when they come through your emergency department. So let's get started. My objectives for this lecture are essentially to review the most common complications, as well as talk about some of the critical interventions that you need to do right away. These aren't things you can sit on. These things have to be done immediately in the emergency department. We're also going to discuss a more systematic approach on how to approach these patients and how to manage them, and also talk about some newer concepts in how we're managing trach patients in the emergency department, especially when they're in acute distress. And the last thing I'd like to touch upon briefly is just some high-risk patients. So patients who you need to take extra special attention to make sure that you're managing them appropriately. So let's get started. The indications for a tracheostomy are basically for upper airway obstruction as well as head or neck trauma. These are things that are going to come in acutely and will often be done right away. The majority of patients that we'll see in the emergency department are patients who are trached for prolonged respiratory failure, specifically those that have been in the ICU for a prolonged period of time and were unable to be weaned from the vent. And this actually is quite common. Up to a quarter of patients in the ICU will require a trach at any given time. And this is concerning, especially because these patients have lots of comorbidities. They're generally chronically ill, and they're often nonverbal and immunocompromised. So as you can see, this list of problems here is just a setup for a disaster. And it can really put a patient who's already chronically ill in a morbidly ill state, especially when they're having complications in with their tracheostomy. So briefly, I'd like to talk about the anatomy of the trachea and the surrounding structures, because these mechanical problems that you'll experience can be traced back to the anatomy fairly often. So the dimensions of the trachea is basically the inner diameter in the adult patient is approximately 12 to 25 millimeters. And this is important when you're thinking about the size of the trach that you're going to be using in the patient. It's composed of 18 to 22 incomplete rings, which we know, and the posterior wall is composed of a fibromuscular sheath. And why that's important is because there's no cartilaginous support to prevent these chronically trached patients from eroding into their esophagus. And that's often why we'll see a tracheoesophageal fistula develop, because there's no barrier or support in the posterior portion of the trachea. Oh, sorry. And this is a diagram of the vasculature, and this is extremely important. If you take a look at the trachea here that's outlined in the diagram, you can see that on the medial portion, there is the trachea, and lying directly in front of it are the arterial structures. This is where you're going to have your innominate artery or your brachiocephalic artery, followed by your carotid, subclavian, and so forth. And why this is important is because the trachea and the tracheostomy itself, if you notice, will end up going somewhere right here. And that's extremely important, because a lot of times when you have complications such as a tracheonominate fistula, it occurs because of the close proximity of the artery itself. So just something to keep in mind. So let's talk about the equipment. You've got to know your weapons in the emergency department, and this is extremely important. So the tracheostomy tube itself is often composed of a few little structures and some additional components as well that will be important when you're managing these patients. So specifically, some things you're going to want to pay attention to when this patient comes into the emergency department is first the brand. And you're going to notice this by, if you look directly on the tracheostomy itself, there will be some letters and numbers as well as the brand stamped either on the outer cannula or the outer flange itself. And we'll talk about that in a little bit, and I'll show you an example of that. But as you can see, the tracheostomy has a inflatable cuff. Most of them have a cuff. There are some that don't. As well as the outer flange, there's a obturator, which is letter D, as you can notice, and that's often used when you're actually inserting the trach, as well as the most important part aside from the outer cannula, or the outer cannula itself, which is the inner cannula. And this often can come out and be disposed of and put back in. But why this is so important is that the inner cannula often has that 15 millimeter adapter that you're going to need to use if you're going to use a bag valve mask or connect the patient to the vent. Oftentimes, if there's not an inner cannula, it's usually one piece, and that 15 millimeter adapter will be directly connected to the trach itself. But again, the inner cannula is extremely important, one, because it can come in and out, but also because it has that 15 millimeter adapter. So what other things that are important about the trach are, aside from the brand, is the size of the trach, which is often measured by the inner diameter, the length of the trach. So depending on the patient's anatomy, they may have a longer trach, and this could be pre-cuff or post-cuff distance, so something to keep in mind, as well as the material. There's a bunch of different materials that trachs are made of. So let's take a closer look at the tracheostomy itself. If you can see on this patient here, there's a tracheostomy in place. You can see that on the outer flange itself, there are a couple of numbers. And what those numbers represent, again, are the inner diameter, and this is how most trachs are going to be sized, is based on the inner diameter. You can see that 15 millimeter adapter that's sticking out of the inner cannula. That's the clear piece there, and that's what connects to the vent. And this can be removed and replaced as needed. So let's briefly talk about the size of the trach itself. As you can see here, the Portex brand often uses the inner diameter, and this can be measured in millimeters as a 6, 7 through 10. And often they're color-coded. So you may notice on that outer flange that there's a color that corresponds with the actual size itself. Now, the Shiley company did things a little bit different. They're going old school, and what they're using is the Jackson-Pratt system. And this doesn't exactly correspond with the inner diameter. What this is the tube sizes go by even numbers, so 4 through 10, but the inner diameter is a little bit different, and there is a conversion factor, but if you just recognize that the Shiley company uses the Jackson system, you can always go a size smaller if you need. But again, just recognize that it's not exactly the same as the inner diameter. That's extremely important when you're approaching these patients. So here are some brands. As you know, there's the Bavona, there's the Shiley, there's also the Portex. Some more of the common ones with the inner cannula are on the right here. And what you'll notice, though, if you approach a patient and you see one of these other types, so the adjustable trach tube here on the top, as well as down the bottom, the Bavona reinforced tube, just recognize that you're going to be in for, you potentially could be in for a rougher course, because these are often trachs that can't be removed and replaced very easily. They're often very patient-specific, so if the patient has a known mass and they need that reinforced tube to protect the airway, you're going to have to start getting creative and call your surgical colleagues pretty quickly if you need to replace that tube, as well as the adjustable trach tube. Sometimes in your obese patients, they may have an adjustable trach, and that's to measure more of the pretracheal space or the anatomical abnormality that may need to be accounted for. So again, all more important to actually know your weapons here. So let's get to the meat of the lecture here and evaluating a patient with respiratory distress with a trach. In my opinion, the most important thing is to keep a systematic approach. You're going to want to approach these patients in the same exact way every time, because the atmosphere can be chaotic, especially when you have a patient with a known or with a tracheostomy, and they're usually very sick as it is. All of a sudden, the adrenaline in the room gets kicked up a notch because these patients are either bucking the vent or they're looking very uncomfortable. They have unstable vital signs. So you're going to have an algorithmic approach, and that's what we're going to talk about today. First, you want to start off with your primary assessment, just as with every patient. You want to do your ABCs, but specifically if the patient's in respiratory distress, please take the patient off of the ventilator. It's extremely important. Don't continue to allow them to, don't keep pressing that mute button on that vent. It's important that you take them off. And why is that? Because when you take them off and you put them, you connect a bag valve mask, the amount of information you're going to gain from the BVM itself is invaluable. You're going to be able to tell if you're having difficulty bagging the patient. If that's the case, you may have a dislodgement or you could have an obstruction. And if you're also noticing the air's leaking around the trach itself, then again, dislodgement or obstruction. Or what about if it's just difficult to bag? Could the patient have a pneumothorax? And also, you want to think about equipment failure. So could you have a fractured tracheostomy tube? Could you have a fractured cuff so there's no longer a seal? And what I just went through here is a mnemonic that I want you to keep in mind. And it's very simple. It's called DOPE. It's the same mnemonic that you're going to use with crashing intubated patients, except you're just using it with the tracheostomy patient. So what we've outlined here is, or what this mnemonic does, is it goes through the most common complications that you have to think about in every trach patient. So dislodgement, obstruction, pneumothorax, and equipment failure. So there are going to be some key things you need to know in your history. And these basically are the who, what, where, how, why, and when. So why was the tracheostomy placed? Was it for an anatomical deformity? Was it for a mass? Was it for prolonged respiratory failure? To sort of give you an idea of what you're up against. And how long has the trach been in place? And this is important. And if you notice here, if you see this in the picture, these sutures, don't even worry about the iodine. If you're seeing betadine on the patient, you know it's been placed early. But stay sutures are often placed in a trach patient who the tracheostomy has only been in for about a week. Usually after a week, they'll take those out. But usually the trach itself needs about 7 days to mature. So if that's the case, be a little bit hesitant about whether you're going to immediately replace that trach. Previous complications are also important, specifically if there have been recent equipment changes. So a lot of times these patients will be at a nursing home and they'll have changed their trach for sort of routine maintenance, and then all of a sudden they'll come in with respiratory distress. And that's extremely important because that's going to give you an idea of whether or not maybe it's misplaced. Also, you're going to want to know about increased O2 requirement. Is there some sort of infectious etiology that's causing the patient to be in respiratory distress, perhaps a pneumonia or an aspiration, or aspiration shouldn't occur, but if there's, the trach is without a cuff, that is possible, as well as any increase in amount of suctioning. So approaching these patients, you're going to get your history, you're going to ask your key questions, and then in my opinion, this is one of the most important things in terms of being prepared, and that's to get your equipment ready. Now, the equipment that I recommend goes along with another mnemonic called the SOAP Me mnemonic, and this was something that was taught to me during residency for when you're preparing to intubate a patient. And so what I've done is sort of revise this a little bit to fit the tracheostomy patient. And what this stands for is basically you're going to want to have 2 suction canisters ready, going with completely turned up with Yankauers attached. You're also going to want to have your oxygen going in an ambu bag. And again, it's extremely important that you look for that 15 millimeter adapter. If it's not there, you're not going to be able to bag the patient. And so start thinking about other options, which we'll get to in a little bit. Your airway equipment, A is for airway equipment. So you're going to want to look at the trach itself, look at the flange, and see if you can see the type as well as the size. And you're always going to want to have a backup, which is one size lower. So if you have a 7.0 trach, you're going to want to have a 6.0 ready. And in my opinion, and this is sort of going to be your backup plan to your backup plan, always have a 6.0 endotracheal tube in your pocket. Because if you can't find a trach that will fit or be able to be replaced with the current one, you can always use a 6.0 endotracheal tube. Some people will say a 5.0, but generally I think if you use a 6.0, you'll be okay. Lastly, again, it's important to have a bougie, and a lot of people will say use these red rubber catheters when you're exchanging a trach, and I think that's okay if the patient's not in respiratory distress. However, if the patient's moving around and it's difficult to sort of replace that trach itself, I highly recommend using a Seldinger technique with a more rigid object like a bougie. So have that bougie ready, and also an 11 blade should you need to cut down, and we'll talk about that a little bit more. Positioning is important. I'm going to show you a video on the next slide of why that's important, as well as your monitoring equipment. And probably the most important monitor you can have is end-tidal CO2. And this is continuous waveform capnography, not your blue and yellow color capnograph or litmus paper. This is continuous waveform, which we'll talk about more as well. So this is why positioning is important. What I've done here is I've marked this young lady's neck, approximately where the cricothyroid membrane is, or the first tracheal ring. And what you'll notice is, as she's in a neutral position, you can see where the X is, but as she extends her neck, that soft tissue moves. And this is important because if you have your patient sitting up or at a 30-degree position and their head's not in extension, that soft tissue can shift dramatically when you're trying to replace that trach. And so when these patients are in the operating room, you must remember that often they're in slight neck extension when the trach is put in. So if they're not in that position in your emergency department, there's no way, or you're going to make your job 10 times more difficult, because you're going to be forced to try and navigate your way through a trach that with some floppy soft tissue in the way, as opposed to in slight extension, which was how the tracheostomy was placed. So positioning here, as you can see, is extremely important, and there's a large amount of fluctuation in the amount of displacement that you can have with just a little bit of neck extension. So as I mentioned before, end-tidal CO2, and this is something that I believe is probably a standard of care in the emergency department now. It's been standard of care in the ICUs as well as in the ORs for years. And what we're recognizing is we're missing so many trach complications because we're not utilizing this technology. And end-tidal CO2 is essentially a Class 1 AHA recommendation for all procedures involving airway. And what you'll notice here, and I just wanted to talk briefly about the waveforms that you will often encounter in the emergency department once you connect the patient. If you look in the bottom left-hand corner of the screen, you're going to see a normal capnograph. And what that shows is end-tidal CO2 fluctuating with respiration with its peak around 30 to 40, and that's normal respiratory variation and normal capnograph waveform. What you're going to see here in B and C at the bottom portion of the screen is either a wavy or a flat line. And what does that mean? That's going to show you that you're not in the airway, that the patient is either not ventilating properly, not ventilating at all, or and essentially the trach could be in the wrong place. And we'll use this in the case examples we have coming up. But again, if you have it, this is probably the most valuable monitor you can have for the trach patient in respiratory distress. Please, please place end-tidal CO2 on these patients. So complications. Let's talk about the complications. Most of the complications you're going to be seeing in the emergency department are going to be your late complications, things that occur over 3 weeks since the tracheostomy was placed. You may see some of the earlier complications, and usually these are going to be your hemorrhage around the trach site itself. You might have a small vessel that could bleed, get irritated. But more commonly, what you're going to see are obstruction, dislodgement, and possibly infection in the early postoperative period. After 3 weeks to a month, what you're going to find is that the most common complications you're going to see are still going to be obstruction and dislodgement, but usually around that 3-week period, you're going to start seeing things like the tracheonominate fistula as well as the tracheoesophageal fistula. While these complications are pretty rare, they do exist, but usually in the prolonged postoperative phase. So not something that you're going to encounter right away, but more likely in the emergency department. So what I have here I'd like to do is go over some cases quickly. So this was a patient we actually had in the emergency department, just came in a few months ago, and this was a patient, he was a 72-year-old male that was brought in from a local rehab facility. He was in a motor vehicle accident and had multi-system organ failure and required a trach for prolonged respiratory failure. When he was brought in, he was unresponsive, EMS was bagging him, and there was questionable bilateral breath sounds, and CPR was ongoing. So what you'll notice in the video is we have a physician at the head of the bed, and what he's doing is going through the ABCs. He's asking all the key questions. And we also had, this was a patient of Dr. Bontempo's, and she did an amazing job managing this patient. But the first thing she asked for, or one of the first things she asked for, was end-tidal CO2. And what we saw on the monitor, which you won't see here, was basically a flat line. And what had happened is the patient had gone into PA arrest because he had a dislodged or obstructed trach. And as we suctioned the patient, we got a large amount of mucus out and essentially relieved the obstruction. The end-tidal CO2 went back up to 40. So let's talk about obstruction. This is the most common complication that you're going to see. In fact, almost 30% of trach patients presenting in respiratory distress will have a tracheal trach obstruction. And why this happens is because the upper airway is meant to essentially humidify the air that goes into the lungs. And once you bypass that whole mechanism is gone. So often you'll get amount of mucus that may get dried out and attached to the inferior portion of the trach. And a lot of times you might not even notice this when you're bagging the patient if they're in respiratory distress, because it can act almost as a hinge, as a ball valve mechanism. And what happens is as you squeeze the bag, that little ball of mucus will open up and then won't allow them to expire. And that can be extremely dangerous, as you know, because you can increase the amount of airway pressure, PEEP, and essentially hyperinflate the lungs, and that can lead to a pneumothorax or something else. So what you're going to notice here is if you look down again at the end-tidal CO2 graph, what you'll probably recognize is it will look like either B or C, where you won't have ventilation of the patient and there won't be any monitoring, or there won't be any detected CO2. So again, all the more reason to use it. But again, the reason why it's so important is because oftentimes your physical exam might not be as reliable as you think. You may be able to bag the patient, you may be able to squeeze the bag, but you can't detect whether or not they're exhaling. They might have clear breath sounds. But the fact is that the air is not getting out and there's an obstruction. And the most reliable way you're going to detect this is with continuous end-tidal CO2. So what are you going to do for this? You're not going to call your RT. As you can tell in the video, that room was completely chaotic. There's no way, and you're not going to have the time to do this. So you're going to be it. So here's what you're going to do. You're going to be prepared. You're going to go through your dope mnemonic. And you got your obstruction there, and you're also going to go through your SOAP-me mnemonic. So your suction, your oxygen, your airway equipment. You're also going to look for your monitors and your end-tidal CO2, and you're going to have that already. And then you're going to think, well, okay, so now what am I going to do next? Just suction. If you can, use a suction catheter, throw it right down the trach, and see if you can get out anything. Then you're going to, if you don't get anything out, then that's not the end of the world. What you may have to do is deflate the cuff. A lot of these patients, though they have prolonged respiratory failure, they can ventilate around the cuff if you deflate it. So next thing you're going to do, if you're not getting the obstruction out, you're not relieving the obstruction, is take that cuff pressure down. Just take a 5 cc syringe, 10 cc syringe, and deflate the cuff. Now lastly, what you're going to want to consider is if that doesn't work, is you may have to replace the tube. You can try taking out the inner cannula, and that's something that if you don't need to bag the patient, that you can take out, inspect it to see if it's obstructed. But if the external cannula is obstructed or there's something on the tip of that tube, please remember, have that 6-0 endotracheal tube in your back pocket. You can always use it. Now you can always consider intubating from above, and this may be an option for the patient in chronic respiratory failure. However, just be careful if this patient has a mechanical problem, such as an upper airway mass or some other reason, that may be more challenging. So let's talk about a second patient. Patient 2, he's a 42-year-old male from a local rehab facility with acute respiratory distress. He has lots of medical problems, as you can see here, and he was trached approximately 3 weeks ago. His vital signs, he's a little bit hypoxic, a little bit hypotensive, and he may have a slight fever with tachycardia. EMS is again bagging him. He's obese, and his SATs continue to drop. What you notice when you actually inspect the patient, his trach site, is you may feel a little bit of crepitus. So this is a classic presentation for tracheal dislodgement, or trach dislodgement. And this often can present slowly or insidiously. And actually, this is probably one of the most often misdiagnoses is a trach dislodgement. So the highest risk patients for trach dislodgement are most often going to be your obese patient, patients who had recently changed or inserted tracheostomies, and difficult past intubations. The classic presentation is going to be the patient who the trach fell out while they were getting moved from a bed to a stretcher to another stretcher, and someone just put it right back in. And they thought everything was fine until approximately an hour later they noticed the patient was in respiratory distress. What most likely happened is the trach tube itself isn't sitting properly, and there's a partial dislodgement. So the pearl here that I want everyone to recognize is that longer trach tubes, and these are ones for more obese patients, can become partially displaced inferiorly because they may not be sitting properly. So what can happen is you can get a little bit of axis rotation, and so what you may need to do is just reposition it slightly. But if the patient comes in with any evidence of subQ air, subQ emphysema, crepitus, think about tracheal dislodgement, or trach dislodgement. So what are you going to do? How are you going to manage this? Again, be prepared, go through your SOAP-ME mnemonic, and then you're going to want to ask some key questions, such as when the tube was placed. Now, again, remember, if it was placed in less than 7 days ago, be a little bit wary about replacing that tube because the trach will close rapidly. And if it's already been, if the trach's already been removed or taken out, that trach's pretty much gone. So you are going to prepare to intubate the patient from above. Also, recognize what size the trach is, again, looking at the outer flange or outer cannula. And again, always have that 6.0 endotracheal tube in your back pocket. You can use it if you're in a bind, especially with a bougie. And beware of the false passage. And the reason why I put this here is if the trach is out, I strongly recommend that you use this bougie with the Seldenier technique, especially if the patient's in respiratory distress, because it's going to be very easy to try and just slip it back in, and if the patient has a big neck, get into some soft tissue or create a false trach. And if you're not sure that you're in, if you don't have end-tidal CO2 available, this is just a disaster waiting to happen. So the last patient I'd like to go through is an 18-year-old male who comes in with a cough, and he noticed some blood in his sputum, no big deal, he said, but he had a pretty significant injury, had a C-spine injury that caused him paralysis. He appears well, he has clear lungs, he has baseline motor deficit, his baseline motor deficits, and his vital signs look okay. So what are you going to do? Is this a minor bleed or is this a major bleed? And really you can't tell clinically. The most important thing that you need to remember is that a sentinel bleed can occur, and that's if anything more than 10 mLs. And 10 mLs is not a lot. If you think about those the syringes that the nurses use to draw blood, that's probably about this big. But especially with the timing, around 3 to 4 weeks, anything over 10 mLs, you've got to call your surgeons in. Take the patient to the OR. He needs emergent bronchoscopy to look for a tracheoinnominate fistula. And so a lot of times these bleeds may not be just from the innominate artery itself. You can get some bleeding from some thyroid vessels as well as the carotid or aortic arch. But I'd be a little bit worried about sending this patient to a CT scanner. He probably needs to go to the OR for a more controlled examination. So this is probably one of the most disastrous complications. It's not very common. Only about 1% of patients will have a TIF. And again, it will usually occur within the first 4 weeks. The most common board-style question will be, this is a patient, a young patient who's tall and thin, and he actually has a high-riding innominate artery. But that's not necessarily true. This can happen at any time. There's been a few papers recently that have done a retrospective review of all their TIFs, and they found that they have occurred even within the first 1 to 2 weeks. and as late as years beyond the tracheostomy itself. The most important thing, though, is if they've had any recent equipment changes, because the trach itself is going to be what erodes into the anterior wall of the trachea. Mortality is about high as it gets in these patients because they exsanguinate rapidly. And this is all the more reason why you need to get them to the OR as fast as possible, because once that clot opens up from that sentinel bleed, it's just a complete mess. I had a video here, and what I'll let you do is sort of look this up on your own if you like. This is a patient from Pakistan who had a TIF. And if you watch within the first minute of the video, they're going to do a median sternotomy. And when they open him up, it's just a pool of blood. This guy actually survived. He was one of the 3% that survived. But again, it's just a complete disaster. And you need to be on top of this as fast as possible. So what you're going to do is you're going to have a double setup. You're going to have and this is where your 11 blade is most important. And the reason why that's important is because if the patient's actively bleeding, you may need to cut, and we'll get into that in just a second. The most important thing you're going to do initially in a patient who's bleeding from the tracheostomy site, and this is actual active bleeding, is hyperinflate the cuff. You can put up to 50 cc's of air into one of these tracheostomy cuffs, and often what you'll find is that increase in volume of the cuff will tampen on the bleeding itself. Now, what if that doesn't work? Well, again, remember, always have that 6.0 ET tube in your back pocket. Use your bougie and put the endotracheal tube into the patient, into the tracheostomy site. Hyperinflate that cuff and slowly withdraw the ET tube itself. And what you'll hopefully do is be able to tamponade the source if it's beyond the cuff of the trach itself. Now, what about digital pressure? Is that a viable option? Well, I did a little self-research on this, and I went to the cadaver lab and tried to give it a shot and see what I found. To be honest, it's really, really hard. If you can see here in the actual picture, this is what the trach site may look like. The hole's extremely small. I by no means have extra large hands, but it's extremely difficult to get your pinky into that trach site. So it's going to be difficult. So what you may need to do if you need to apply digital pressure is actually cut down through the second or third tracheal ring in order to get pressure. And what you're going to often need to do is this will be around an endotracheal tube, which all, again, just makes it even more challenging. So I don't know that this is necessarily a viable option. I would start off with your hyperinflation of the cuff, and then use your endotracheal tube as a last resort. If you had to use digital pressure, give it a shot, but just as a warning, it's going to be a challenge. So in the last minute or two, I'd just like to talk about special populations, because these are some of your highest risk patients in the emergency department. There was a recent study done out of England. It's a great study. It's a retrospective review of all the complications in airway patients with airway issues. It was the NAT4 study. I highly recommend you cruise through the ED chapter because it was completely eye-opening in terms of what we're doing wrong in managing these patients. What they found was actually obese patients have the highest number of complications, which isn't overly surprising given their abnormal anatomy. But what you'll find, what I didn't realize is that the respiratory physiology is actually completely altered in the obese patient. Their functional reserve actually goes down exponentially with their BMI. So at the start, they're already behind the curve. So you're already going to have to get on these patients even faster than you would a normal patient. They actually have 2 to 3 times the risk of a normal person, and they often have, like we were saying before, some unusual trach tubes, which can make it more challenging. The biggest pearl I can give here with the obese patients is be highly suspicious of a trach dislodgement in respiratory distress. And this is partly because they have that abnormal anatomy, and the trach tube can just go all over the place if it's not seated properly. So it can be more of a challenge to recognize, but again, you're going to need to go through the same precautions with even more important. It's even more important that you use your end-tidal CO2 here. So you're going to prepare the same way. Again, go through your SOAP mnemonic, and again, using capnography, please connect this patient to the capnograph, because again, if dislodgement actually occurred, the only way you may be able to recognize it is by seeing an absence of a waveform. You may need to use a fiber optic bronchoscope in order to confirm placement, but the capnograph is actually one of the most reliable things you can have. And again, have a 6.0 end-tidal 6.0 ET tube in your back pocket, because that will compensate for any excess pretracheal space. So just to conclude, always be prepared. Go through your mnemonics, your DOPE mnemonic, your SOAPNI mnemonic. Obstruction is the most common complication. Dislodgement can be subtle. Always use a capnograph and have an end-tidal or a 6.0 ET tube in your back pocket. You never know when you're going to need it, and it can be probably your most valuable tool aside from the end-tidal CO2 monitor. So again, I'd like to thank you. Thank you for spending time with me. And if you guys have any questions, please feel free to email me or Amal. My email is johncgreenwood@gmail.com. Thank you.